Hello and welcome to Dragon Bytes, the pediatric podcast aimed at pediatric trainees or anyone interested in child health. I'm Asim, one of the pediatric trainees in Wales and one of the hosts for Dragon Bytes. This week we've got another one of our career podcasts for you. One of our newest hosts, Hannah Davies, is going to be exploring the application process for Palliative Care Grid and how to interview for it. She's going to be discussing this with Palliative Care Consultant at the Evalina Hospital in London, Lizzie Bendle, and with current Palliative Care Grid trainee in Wales, Tim Warlow. So let's get started.
Hello and welcome to Dragon Bytes. This week we will continue our series about paediatric grid training. In this episode we will focus on paediatric palliative care grid. I'm delighted to be joined by Dr Lizzie Bendle, paediatric palliative care consultant at Evalina Hospital, London, and Dr Tim Warlow, a paediatric palliative care grid trainee in Cardiff, who has just CCT'd and has managed to secure a consultant job in Wessex. Massive congrats, Tim. Thanks for joining me today. Welcome, guys, and thank you very much for joining.
Thanks, Hannah. Thanks for asking us.
Thank you, Hannah.
Fab. So let's just crack on, and could both of you maybe start with Lizzie and just say how your medical career has gone to date and where you started, etc.
Yeah, I will do. Thanks so much for asking us to do this podcast, Hannah. It's really good to be part of it, especially good for me to be back in touch with some of my Welsh colleagues. So I went to Cardiff Medical School way back when, and then did my foundation training in Wales. I did all of my training in Wales actually, so did paediatric training, and then as part of a registrar training post, just a general peds post, I did a palliative care 6-month post in Cardiff because they had a vacant grid post, and I really enjoyed it, and it made me fall in love with palliative care. So then I applied for the grid, and at the time the only full-time palliative medicine training post was in Cardiff, so I stayed in Wales and completed my training there, which was really lovely to be amongst the fabulous colleagues that I'd already met and learning and honing my skills. I CCT'd 3 years ago now, and moved up to London to work at the Evalina London Children's Hospital, covering a locum post initially, and now I have a substantive post there. So I'm a paediatric palliative medicine consultant up at the Evalina in London.
Fantastic. And Tim, do you want to tell us a little bit about your story?
Yeah, so I'm Tim Warlow. So I trained in Birmingham University, which was a fantastic city, place to be. I did a BSc in public health and then did medicine there. And then I was a 7 trainee for my paediatric training. So foundation and paediatric, rotated through 7 deanery, and then moved to Wales, having never done palliative care before, to do the palliative care grid post, which I've just finishing today. And then I'm moving next week to Wessex to take up a consultant post there in paediatric palliative medicine.
Oh, congratulations, Tim. It's definitely well deserved. And with the both of you, what was it that attracted you to paediatrics in the very beginning?
So for me, I think I always enjoyed the aspect. I knew I wanted to do medicine and not surgery. I really like getting to know people and having more of a holistic care around them. I actually wasn't quite sure whether I wanted to be a GP or a paediatrician, but initially through medical school. But I really enjoyed my paediatric training, and just my love for it grew as I went through training. And I think it's just being able to have the chance to work in such a variety of different specialties and different age groups. So working from all the way from a neonate right up to huge 18-year-old boys, like adults. It just gives you such a good variety of work, and you get to see how a child develops all the way through life, and also looking at them as a child within a family and all the different illnesses they can have. And I think it's been mentioned before in previous podcasts that pediatrics adds an extra challenge when they're little and that they can't tell you what's wrong, and it's a real sort of scientific and clinical specialty that you have to use your clinical acumen and try and diagnose and treat accurately. And then it's a joy because children get better much quicker once you get the diagnosis and treatment right. And then for palliative care, I think Am I allowed to talk about that now, Hannah?
Yeah, of course you can. Yeah,
So about palliative care, it was just, you have that extra dimension of being able to support families, and there's a lot more you can do than just try and cure their immediate illness. You actually get to know the families, children and young people and their families much more, with their longer term complex conditions, and find out what's important to them and really improve things for them, and work alongside the other teams looking after them. And it's a really privileged job, because you will come on to it, I'm sure, as we talk more about palliative care, but you get to be with them in a really special time in their life and support them in a unique way.
Yeah, I totally agree. And Tim, what about you? What drew you to paediatrics and palliative care?
Yeah, so I think similar to Lizzie in one sense, I really enjoyed working with children and families, and the complexity of that parent-child interaction, and the challenge of diagnosing and treating children when they can't tell you what's going on. I felt that it was really clinical medicine at its best. So that what really was part of what drew me to peds. And then I think during my early pediatric training, I really enjoyed working with children with neurodisability, because they often have very complex symptom clusters. The families are going through just such a tough time, day after day, year after year, and the services around them are just not really designed to meet their needs often. And they're faced with difficult decisions. And I think it just really struck me that this group of patients has a real need for that kind of extra symptom control and support, as Lizzie said, in the kind of longer term journeying with the children and families. And I suppose the other aspect is, as I was going through my tertiary rotations in Bristol, really seeing the need for support for teams in making difficult decisions about prognosis, and also managing difficult symptoms, particularly neonatology and cardiology and oncology. There's often a lot, real complex symptoms that are a mixture of kind of psychosocial and spiritual and physical, and really saw the need for that expertise there. And I think that links on to, again, what Liz said. It's such a great challenge, because there's so much pharmacology. You're applying a lot of evidence from adult medicine. It's very bespoke and creative in terms of the medicine, but you've also got the clinical challenge, the communication challenges with the family, and yeah, and you've got the flexibility, but like in some ways, if in your day, if you want to spend a bit longer with this family to really get to the bottom of what's going on, then you can. You're not pressured by having to get the ward round done by a certain time, those sorts of things. You've got a bit more autonomy. So all of those, really, I just thought, this is really what I want to do.
Yeah, guys, you're really selling it. So now you have a good experience of what the Palliative Care Grid is. Why would you recommend it to future possible palliative care doctors?
So I think Tim's already alluded to it, but for the attraction for us for palliative care hopefully has come across in what we've already said, and how you can really work for the child and look at not just the physical but also the emotional, social and spiritual aspects of that child and that family, and how to support them. And I think the grid training is also an attractive training to be involved in. We're a very small specialty. There aren't many consultants throughout the country, and there are only 3 grid training posts across the country currently. So even though that means that we're restricted as to how many people can train in it, it's actually, we're a very small world and we all know each other, and there's good working between the different teams across the country, and the opportunity to have good training and expertise and experience by going to do shadow visits at other centres. And then whilst we're talking specifically about the Welsh training, so Tim and I both thoroughly enjoyed our grid training in the Welsh Deanery. We were based in Cardiff, but across the All Wales Children's Palliative Care Network, so we had the opportunity to go out to West Wales. It might be better for Tim to talk about it because mine was a few years ago in case things have changed, but you get to go all over Wales to support children and families and meet the professionals there. And it's based in hospital, it's based in the community, on home visits, going to the hospice. It's a really varied and nice specialty to go into, from the hecticness of being a paediatric registrar, being in the hospital what feels like forever, doing night shifts and weekends, and whilst you still have some on-call commitments, you actually in the daytime when you're doing your palliative care, you are in charge of your time a lot more, and you can have that time to get to know the families. And palliative care teams across the country try to not add to the burden of families by bringing them back to hospital appointments all the time, like we do go on home visits, and you get a real unique insight into that, the family and the child, and what's important to them and what's practical that you can do to help improve things. And I think Cardiff has the Welsh Deanery has the good mix of the non-malignant diagnoses of life-limiting, life-threatening conditions, which is the bulk of children's palliative care. So work, as Tim's already mentioned, working with children with neuromuscular problems, neurodisability, inherited metabolic disorders, cardiac failure, kidney problems, all sorts. You intermix with all the different specialties, and also oncology, which is what people generally think about palliative care first. And whilst there is a significant workload with the oncology cohort, it's important to acknowledge that for paediatrics, the non-malignant specialty is also very important, and actually the larger part of our caseload. And then for the grid training, we have the national teaching sessions that are set up through the CSAC. So the trainees set up national training, which is often in London, but tries to be around the country and can be joined virtually now, especially. And as I say, you can go and visit any other team and work with them, spend some time with them, and any hospice that is open to visitors. So it's a very open and cohesive workforce across the country, keen to try and encourage new people to join.
So Tim, do you want to just tell us a bit why from your opinion, why a trainee should choose palliative care?
Yeah, absolutely. So I think there's definitely something to be said for that autonomy in your working day and your working week, and in terms of you've got control over your schedule, and you're in such a variety of places, meeting so many professionals. I think for me also, quite a few people were surprised when I did palliative care because I really enjoyed emergency medicine. I really enjoyed the kind of more, typically adrenaline filled specialties. But actually, my experience in palliative care is that you'll have days where, with an hour's notice, you have to meet a family, counsel them about the end of life, transfer them to the hospice, and oversee extubation, including all the symptom management. You may have episodes of acute severe pain, which you're having to manage really like an APLS scenario, including all the human factors and people around and supporting staff and those aspects. And then you've got patients who you get to know over years. I still see patients who I saw on my first day doing grid. And that again is just a great pleasure, doing that journey with the families. So a huge clinical variety. I think as well. So I think that's what I would add to what Lizzie said, really.
Yeah, and after working with you both, I can't imagine the both of you in any other specialty. I think you're so perfectly matched palliative care, honestly.
Thanks, Hannah. And you're welcome to join us anytime.
I used to just sit in awe of your communication skills, because I think that's a really key thing that I've picked up from the both of you, your ability to put the parents and the patients at ease almost immediately, and just the way you speak to people is just beautiful. So I'm glad you chose this specialty, and I'm glad that our patients have you. So just thought I'd add that in.
Thanks, Hannah. I think it's important to say that you don't have to have excellent communication skills to join palliative medicine grid. You are taught how to do that, and you get the chance to learn that as you go along. So don't be put off if you feel, oh gosh, I couldn't handle being in charge of those difficult conversations, because that's nurtured throughout your training.
And talking about difficulties, obviously, people associate palliative care always with end of life rather than maybe symptom management through chronic conditions. But I was just wondering, with such an emotional caseload, how do you guys deal with that? And we'll start with Lizzie.
So I think it's important to just expand on that a little bit. So yes, it's true that we do part of palliative care is end of life care, and it can be emotionally challenging. But the bulk of our work is actually symptom management and advanced care planning for families with longer term, more complex conditions, and supporting the families through those decisions and the trajectory of their child's illness. And actually, one thing that I found quite refreshing about when I started in palliative care was that sadly, children do have conditions that can't be cured sometimes, and sadly, some children do die in childhood. And actually, most of our career within paediatrics, you're doing your very, very best not to let children die and to keep them alive and to keep them healthy. And sometimes, sadly, they will pass away, and actually, it you feel like you've let everybody down if a child that you've looked after hasn't survived. Whereas when you move into palliative care, actually, it acknowledges that sadly some children are going to die. And instead of fighting that death and trying your very best to avoid it, you acknowledge that it's going to happen and you try and help the child or young person and their family to actually find some element of hope and comfort for their remaining time that they have before their death, and to try and make things as good as possible for as long as possible. And actually, it's really the focus shifts from, instead of focusing on their death and trying to avoid that, you actually focus on their life and what they can achieve and what they can still do and what's important to them. And being able to help a child have their symptoms under control so they can go to a theme park or have that weekend away or something is huge. And it's actually quite a fun and celebratory specialty in that way, because you get to know families and help them to facilitate some happy times together and some fun and see what's important to them outside of their illness. So whilst it is sad, there is actually quite a bit of happiness and laughter in palliative care. But I think it's important to acknowledge that, yes, we do have to deal with quite sad and emotional things as well. But as Tim's already mentioned, you work alongside other teams and other professionals, and it's a really well supported specialty to be in. You're not on your own. You're in a team with specialist nurses, physios, community teams, other allied health professionals, and you all work together, and you're not expected to be on your own dealing with really emotional situations. And if that does happen, or if being within a team it's still upsetting for you, then we have the chance to do debriefs and to have discussions with the teams. It's acknowledged within people that by people that work within palliative care that it is emotionally challenging, and so there is an important focus on supporting each other through the different challenges and being open and being able to say, that must have been really hard for you. Should we have a sit down, catch up, and talk about this? And we try to offer that as medical professionals for the allied healthcare professionals around us and the teams at the hospices, and offer debriefs and the chance for people to reflect on it and just feel free to talk about what went well, what was challenging, and what learning points we might have, but also just the space to be able to say, that was horrible, I found that really hard, and to be able to talk about it.
Yeah, fantastic. And Tim, what about you? How do you feel that you deal with the emotional side of things?
I think one of the things for me was it makes you really intentional about how you look after yourself, and where you get your energy and your momentum from. One needs to really nurture. We need to really nurture ourselves in order to provide the care that we provide. And I always think of it a bit like a tank of fuel. If you get to the bottom of it, you're not going to be able to run the engine, and actually, we need to be constantly refilling. So it makes you intentional about what I need to do this in long term in terms of my career. And I think also you learn an awful lot from the families about from how they approach caring for themselves, and their views on their own, on the bigger issues in life. And for me, I find that quite therapeutic, and I think it's helped me to learn an awful lot about myself, and so that really you can be resilient to do this and support these families in the longer term.
Yeah, no, that's brilliant. And Tim, with you just CCT, and you're probably the best to ask. So could you just give our listeners a bit of an insight to what the training program involved and how long it took?
Absolutely. So the Grid training program is it's officially 3 years, but you do 2 years of specialist children's palliative care at one of the 3 main centres. So that's in London, in Great Ormond Street, in Wales, and in Yorkshire and Humber. So in that 2 years, you spend 18 months doing paediatric palliative care, and 6 months or equivalent to in adult palliative medicine. So that was for me was quite an eye opener, spending a period of time in an adult hospice, going back into adult medicine, and caring after elderly who were dying from cancer. I mean, fantastic experience doing that. And then in addition, you've got an extra year. So once you've done those 2 years, you've got a third year, which you can choose what you do for that year, really. So it depends on what previous training you've had. You may want to do some oncology, some neurology, intensive care. Those are the typical things, but there are many other opportunities. So you in that last year, really, you piece together from your own learning needs, what you need to fulfill, your competencies, and fill the gaps in your training.
Brilliant, that's fantastic. And guys, are there any specific learning requirements that you have to achieve by the end of your training?
So just you have to do the START assessment, which all trainees have to do. There is a diploma in paediatric palliative medicine, which isn't required, but it's recommended. That's run through Cardiff University, so most trainees do complete that. But otherwise, it's just completing your curriculum competencies as you go along.
Fantastic. And when you were both applying, is there any general advice you'd give to our potential listeners who are interested in palliative care?
Yeah, so I think there's one of the things people often struggle with is the fact that there aren't rotations in SHO training for palliative care, and makes you think, well, how can I know that I'm going to like it? How do I know that I'm going to get on in the specialty? It's obviously a big commitment, isn't it, applying for Grid, especially when it may involve moving locations and things. But I think one of the things that I found was that palliative care is happening in all the time in all the hospitals and settings that we work, whether it be on neonatal units or looking after children with cancer or neurodisability on general paediatric wards. So I think the main thing would be making the most of the opportunities around you to get involved with those patients. Take the opportunity to be caring for them, to follow them through that clinical journey. And in addition to that, I think there are other opportunities to get a taste of the specialty. As Lizzie mentioned about the national training days, they're a really great resource because you learn some palliative care, you get to meet the consultants and the other trainees and get a feel of what the specialty is like. Every year, the Association of Pediatric Palliative Medicine runs a study day, which is like a national conference, where again you get that sort of networking and can ask all those questions about the training, and there's often separate seminars for those interested in the Grid training.
So how would we get in contact with people to get access to those days and study days?
That's a really, really good question. So if you go onto the Grid website of the RCPCH, there's contact details for the CSAC, including the trainee rep. So that would be the person to contact, and I believe there should be an email attached to that. So that would be the first port of call. And I think the other thing is get in touch with your local hospice. The hospices are very happy for professionals to come and do a visit and see what it is that they do. We have lots of different visitors at the hospices. So that's another real side. that you can access. And of course, use your taster days and get in touch with your local tertiary palliative care team. Now, most areas of the country have got a tertiary paediatric palliative care team, and what I did was I rang up the hospital in Cardiff and asked them to put me through to the registrar, and I spoke to Lizzie before and asked her a bit about it, and asked her what the grid training was like here, and that was a fantastic conversation. I remember that. You may not remember, Lizzie.
Lizzie, you must have sold it so well.
I know, must have caught me on a good day, huh?
So I think you have to be proactive, and you have to be willing to sort of get out there and get the experience. But I think it's there to be had.
And I think everyone, sorry Hannah, I interrupted you, but I think because it's such a small specialty, everyone is aware that people don't get the exposure to it necessarily. And so any team would be happy for you to contact, and all the hospitals take visitors from other places. So when I was in Wales training, we had visitors from Canada, from different sites across the country. Like, people can come and do observerships or a taster session, and that's really welcome. So you can just phone up or email whichever hospital you want to try and get in touch with, or ask contact the current trainees or past trainees. We're all very happy to be emailed or called and asked. And just one thing about the APPM, so the Association of Pediatric Palliative Medicine, their study days, if you're interested in that, all the links are on the website, and you can contact the team through the committee through there. I'm actually on the committee, so there's a trainee representative group on the committee as well, who would be happy to answer all your questions as well, and then information. The chair, the secretary, any of us would be happy to be contacted to put you in touch with people locally, and to find out more. And also the team in Wales, so Richard and Megumi and Joe would all be happy to be contacted, I'm sure.
Oh, that's brilliant. Thanks, guys. And for those who may have left it a little bit late before getting their CV, etc. ready, is experience necessary, do you reckon, to secure an interview?
No, it isn't. I think enthusiasm is the main thing that's necessary, and an awareness that you've done your best to try and find out a bit about it. The CSAC committee know that people haven't necessarily had the chance of doing it before. Most of us hadn't. I was lucky, I had 6 months of doing it, well, actually only 2 or 3 months before the interview, because there was a grid vacancy and I was doing it as a PEDS rotation. But most people haven't had the chance to actually work in paediatric palliative medicine. But I think, as Tim said, if you've found out, contacted your local team, tried to visit the hospice, or done some study days, or contacted trainees to find out, then that's the main thing. And also look at what skills you have that are transferable. So a lot of what we do is mirrored by the MDT approach for a child with complex medical problems. So if you look at neonates, as Tim said, all the way through to children with neurodisability, and then specific cancer diagnoses, they all have the same model within palliative care of addressing the physical, the emotional, the social, and the spiritual care. And good paediatricians do that on a day-to-day basis, but don't have the time to actually spend that much time doing those extra holistic bits on a busy ward round. Whereas if you can maybe just think about that during your care, during your training, and think, how can I demonstrate that I'm thinking more holistically about my patient group? And is there an audit I can do that looks at support children have in the community when they're home, or discharge communication, or allied healthcare professional support? Like, all of that shows that you're thinking about those other aspects of the child's care.
And in regards to, once you've ticked all the boxes and done all your forms, how do you reckon you could maximise your chance of getting an interview?
I'll let Tim answer.
Yeah, of course. Yeah, so I think as Lizzie said, it's about making sure that you're demonstrating that you've sought to find out about the specialty and contact the right people. I'm just looking over my grid application just today, and it's quite generic. And actually, a lot of those skills, leadership, management, quality improvement, teaching, training, are all things that you have to do right from ST1. And so I think it's about honing what it is that you're having to do anyway for training, to pull out those themes. And I think the danger with palliative care, as well as some of the other smaller specialties, is that people can feel, well, I haven't got a palliative care team locally, therefore I can't do any palliative care. And I think that's really not true. I think have a look at the service that you're working in. So one of the things I did, I was quite late thinking about palliative care, really, and in ST5, I think ST4 to 5, I was working on bath neonatal unit, and myself and one of the band 6 nurses were really interested in palliative care, and so we, set up, a quality improvement project around that. We did some education sessions for the nurses. We got together some resources. We ended up publishing that and presenting it at the RCPCH conference. So if you think, that was a level 2 NICU, in a DGH, and you can pull together all of your different strands there. There's some leadership there, education, governance, research, all around one project that really demonstrates that you want to make a difference in this. So it doesn't have to be tertiary or highly specialised. It's seeing the need where you are and acting on it, in a way that you can reflect in your portfolio and your achievements, really.
That's brilliant. Thank you so much. And guys, can you remember that interview day, and how do you think it went, Lizzie?
Yes, I can remember the interview day well. So it was obviously daunting, because it's something you really want to do, and none of us, when you're in training, you actually don't have any interviews, that many interviews throughout your training once you've got your place on your specialist training program. So we're not particularly well practiced, but I had some practice and help with colleagues around me and previous trainees. So the interview was up at the Royal College. We had to prepare a presentation, and it was a generic presentation about what is paediatric palliative care, if I remember correctly. So as long as you've read up a little bit about it, you can do a presentation about I think it was what is paediatric palliative care, and how can I demonstrate my skills within it, or something like that. So it was not too onerous to do on the day. And then there were a panel of consultants from across the country, and RCPCH representatives, and they asked, I just remember them, I can't remember the specific questions now, I'm sorry. I can remember my consultant interview questions if anyone wants to know about that. But they were very friendly, and they weren't asking you to be a specialist in opioid pharmacology or ethical dilemmas. They were asking you to show what you've done, as Tim alluded to already demonstrate that you can think holistically about a child and their family. So there was a clinical case and how you would manage. I think it was you're on the ward round, and there was a child who's in pain, and the family would like you to assess it. How do you approach that? So it's just thinking about the holistic approach to pain and how you would assess it, and what further information you try and get, and how would you follow that up. And then they asked about what communication things we've had, what examples of different challenging communication scenarios, examples of leadership and teaching, the same sort of things that's asked at all of the grid interviews, I'm sure. And then also the challenges of research in children's palliative care. So acknowledging that research in pediatrics is hard enough, but for palliative care cohorts even harder. There's not very much children's palliative care research that happens due to the ethics of trying to have research studies in that cohort. But talking about how we extrapolate evidence from adult data, and how it's important to acknowledge that maybe some people have put off trying to do research in children with life-limiting conditions, but there is stuff that can be done, and actually families and children might want to be part of research studies. So thinking about what is important to them and what things they might want to be involved in. And on the whole, I remember it being a friendly panel. There was lots of smiling, and I was made to feel welcome. And whilst I was terrified, actually there weren't any burning questions that I remember that were awful. You just had to demonstrate that you're enthusiastic, you knew a little bit about it, and you wanted to learn more about it.
And what about you, Tim? What was your experience?
Well, yeah, it sounds like I had exactly the same stations, and very unimaginatively. So yeah, it was essentially the same stations, but I think the themes, if I think about the themes from the interview, it was really about them saying, actually, is this a colleague that I could see myself working with? So about being real and genuine, and demonstrating a genuine passion for this patient group and the work that's going on. Communication. Can this candidate communicate? And again, not advanced communication skills, but you're talking about interacting, positively with your colleagues. Do they understand, holistic care? This idea of the, psychosocial, spiritual, and physical elements, and that was certainly a question that I had, was explaining holism. So that's something that's a kind of fundamental principle of the specialty, really, and then really making sure that you understand the general principles of children's palliative care, and two really good resources for that is the Oxford textbook of children's palliative care. The first few chapters really go into detail about that holistic care and that ethos of children's palliative care, and also the Together for Short Lives website, which has got lots of resources and pathways. So I think being immersed in that sort of reading, with, I think is what they're looking for when you come to interview, that you get it, that you understand palliative care.
That's brilliant. Thanks, guys. So talking about resources, so we've got the APPM, the CSAC, the Oxford Book of Palliative Care Medicine, and Together for Short Lives. Is there anything else, or any other resources or signposting you would recommend for our listeners to maximise their exposure to palliative care medicine?
And those are the main ones. There's also the ICPCN, which is the International Children's Palliative Care Network, and they do some online webinars and things sometimes, which are quite useful. So they've done a few through COVID, talking about how it affects children with palliative care diagnoses. But yeah, those are the main things currently happening. Obviously, there are various, like, universities across the country do diplomas and masters in pain management, in ethics, in palliative medicine. So if people are interested in doing more formal further education, then those opportunities are also available to you. And as Tim said, there's a lot of transferable stuff from sort of emergency medicine and resuscitation through to communication and ethics, and there's a whole scope of interest that you can develop within palliative care that you could already have found an interest in another allied specialty.
That's brilliant. Thanks, guys. And just final question, Tim, you can go first. What is your favourite aspect to you personally about your role as a palliative care doctor?
I think I think my favourite aspect is really the challenge of bringing professionals and families together to achieve the best outcome for a child. Thinking particularly about those difficult decisions around prognosis and life-sustaining treatment. And I think having success working with a family and professionals to achieve consensus and achieve the best for the child is just such a satisfying thing, and one of the most challenging aspects of the job as well, I think.
That's amazing. What about you, Lizzie?
Yeah, very similar, really. So I love my supportive colleagues, and most people who are in palliative care are friendly and supportive and good communicators, and everyone looks out for each other, so that's really lovely. But I think from a patient point of view, seeing parents of a sick child go from a point of absolute devastation when they've had a diagnosis of a terminal condition, or that the prognosis is really poor, and being able to help them have a little bit of control over such a terrible situation that's really out of their control, and to be able to facilitate and give them the chance to focus on their priorities and how to make the situation reflect them as a family and achieve the things that are important for them. And then if you can do that, which we can usually with enough time and help, it's a real joy and satisfaction to see families actually having some moments of comfort and, as I said, laughter or enjoyment in a really hard time, and just making some positive memories and having quality time with their children and siblings and family around them. there's nothing nicer actually than being able to help people in their worst, most challenging time of their life, and it's a real privilege to be part of that.
That's amazing. Thank you so much, guys, for joining us today. And you've probably sold millions of people on palliative care medicine, and there'll be no jobs for us all after we've all applied. But thank you very much, and I wish you all the best in the rest of your careers and your future career as a consultant, Tim.
Thank you very much.
And you both take care, and thanks for listening.
And you, Hannah, thank you.
Thanks, Hannah. Bye.
And thank you to Hannah Davies for hosting that podcast, and to both Lizzie Bendle and Tim Warlow for coming on as guests and helping all of us who are thinking of applying to Palliative Care Grid. Please join us again next week for more career podcasts. Thank you for listening to Dragon Bytes.